Let's get going. This is what we're covering today. The intro is going to be extremely short, just one slide, because you all know what PGDs are. We're then going to look at the UK MEC, then combined methods, POP, Depo, implant. There's then going to be a quiz organised by Sue and Janine. Then I'll just do EHC, and then we'll follow up with Caroline, who's going to do adrenaline and lidocaine. Okay. Interruptions are allowed throughout, but talking amongst yourselves is not, if that's okay. Okay, so patient group directions. So they're written for patients that aren't individually identified before they come to you. If you're ever in doubt about something whether the patient that you're seeing fulfills the criteria of the PGD, seek advice. If you can't get advice, don't issue. And again, regular supervision is probably quite key to this. So that's all I was going to say about PGDs. If anyone wants to ask anything else, ask Vicky Buddo back there. Any questions, anyone? Okay. So, UK MEC. Now, we're currently working on the 2009 UK MEC. There's going to be, quite likely, a revision of the UK MEC next year. So there should be some changes, and if the minor changes, we'll keep the PGDs. If they're more significant than that, we may have to change some of the PGDs. So you've got 4 categories. Category 1, always usable. Category 2, broadly usable. And that's where the advantages outweigh the risks. 1 and 2 are included in your PGD. 3 is where the risks outweigh the advantages. And there is the occasional time when we might use that, when we don't think we've got much in the way of alternatives. But that would be an unusual situation, and that would be for an experienced contraceptive doctor to authorise or actually see the patient and action. 4, no for anyone, doctor or nurse. Just one thing about UK MEC, and I know you're all aware of this. It looks, doesn't it, at just single conditions. So it's probably quite important to say that there might be several conditions, none of them UK MEC 3, but you've got to bear in mind if you've got maybe 2 UK MEC 2, that in itself might stop you wanting to issue to that particular patient. You've also got 2 categories, initiation and continuation. Initiation means a woman's got the condition before you put her on the contraceptive method. Continuation means she didn't have it, but when you put her on the method, she developed it. And so if you think of it in that way, then continuation actually is a little bit more medically concerning than initiation. An example is a woman who's got pre-existing focal migraine. She comes to you, she wants the contraceptive method that gives her regular cycle. She wants the combined pill. Now that is UK MEC 2 for focal migraine, non-focal migraine that she has prior to you giving her the CHC. However, if she's got no migraine and you put her on the combined pill, and then she develops non-focal migraine, then that is UK MEC 3, and you would have to stop her, because that means that the pill may have been instrumental in causing her symptoms. Is that okay? Now I'm going to look at all of these, but rather than me just telling you, I thought I might ask you. Okay, so age, first of all. If we just put things into 4 categories and just stick with them. Category 1, combined hormonal. Category 2, progesterone-only. Category 3, implant. 4, Depo. Okay, so of those 4, which 2 have no age restriction in your PGD? Progesterone only, yes, correct? An implant, yeah. And what's the restriction on the combined hormonal contraception?
35 and smoking.
No, we're age, we're on age.
Yeah, but it is 35 for smoking.
Okay, just, we'll come on to that in a second. Upper age limit?
50.
Yeah, okay. And Depo?
49.
Yeah. Yeah, I think, actually, I think in your COC it's 49.50, I think you should cut off. Okay. So there we go. Now, the other thing which I'll come on to as well is just your caution with your Depo and your under 18s and your over 45s, but I'll come on to that when we talk about body mass index. Are the Cumbria PGDs the same as ours still?
I'm just saying, I thought I was said for if an implant with the upper age.
No.
Yeah, it does. It definitely does.
Oh.
I need to check.
I know. A bit surprised.
Maybe we have a little.
Okay, so the next thing I'm going to ask for your opinion on, breastfeeding. Okay, what's the restriction on breastfeeding? Those 4 categories. Thank you, Maureen. Yes, combined pill, and the restriction is?
Less than 6 months.
Less than 6 months and fully breastfeeding. Okay, so that is the restriction. With your progesterone-only methods, you're perfectly okay. In this category, just here, less than 6 weeks postpartum, it's thought that the combined methods might reduce the volume of the breast milk. And less than 6 months, those 2 categories, postpartum and combined methods. It's really quite effective anyway, isn't it, breastfeeding? 98%, so you don't really need combined methods. Okay. Now can I ask you about postpartum and not breastfeeding? What's your restriction?
6 weeks. With it combined. 3 weeks and combined pill. I can't have it.
Yes, 3 weeks, 3 weeks. And why 3 weeks in the combined pill, and why might that be? Yeah, it's clotting, isn't it? That's your worry in those first 3 weeks. Your postnatal period is the highest risk of VTE, and the combined pill would accentuate that. Okay, so you're doing really well. Smoking. I think Sue wanted to tell us about this. So would you like to tell us, Sue? Yeah.
Yeah, if they a 35 and a smoker, then the combined pill is
Okay, yeah, and that's any level of smoking, and 35. However, if she's over 35 and she hasn't smoked for 1 year, the risk actually reduces quite rapidly, and it's reduced by 50% at 1 year of no smoking. So it actually goes down to UK MEC2. And the risk that we're concerned about here is cardiovascular ischemic events. Okay. Now can I ask you obesity, BMI? Louder voices? Yeah, 35 for which method?
COC.
Yeah. Any of the other methods have any weight restriction?
No.
You're too good. Okay. VTE, thrombosis. Okay, so which method has restrictions, or which methods?
Combined pill.
Combined pill. Any others?
Depo, I think if it's recently diagnosed, or on certain treatments, I think.
Okay, anybody else want to put in their pennies worth? No, I'll just add a bit S on methods just to confuse you actually. Yeah, it's a method.
That's a 2.
Yes, yeah. It really is only the combined pill, and it's having had a VTE, currently got one, and that family history where it's happened under the age of 45, over the age of 45. I know everything is sort of just a cut-off, but you have to have it somewhere. Over 45, you're okay within your PGD.
Would you not take into consideration if that first-degree relative under 45 had got it due to something they were doing?
But that's when people ring me. Someone rang me the other day, is it Hazel?
Yeah.
About the alcoholic father who... I can't remember. Yeah. So if something happens to... that was yeah. So if there's other factors other than the health of that person, like external factors like lifestyle, that your patient hasn't got, then obviously we will take account of that, but you probably need to get a doctor's opinion to go ahead with it. Immobilisation. COC. And what's if someone's undergoing, I know you know all this, yeah, major surgery, right? Major surgery, more than 30 minutes duration, and it usually covers like your general surgery, orthopedic surgery, trauma, neurosurgery, things that immobilise you. Your advice to the patient is?
Stop it 4 weeks before.
Yeah, 4 weeks before, and then you can restart it when they become mobilised. Okay. And then the other issue, of course, is you wouldn't use combined methods in people who are immobilised anyway. Migraine. Okay. Any methods restricted with migraine?
With aura. Migraine with aura, COC.
Yeah, or at that we just talked about it. Migraine with aura, or
Migraine without aura, that starts when you...
Yeah. That's exactly it. So it's migraine with aura, or migraine without aura that commences after you've started your COC. Okay, they're your 3s and 4s, they're outside your PGD. Nothing else is. Now then, usually, just have a little talk about what is migraine, because I feel that there continues to be a little bit of confusion. Those of us who have migraine never get confused. And for those of you who watched the John Gilbo talk, he always, again, it's not his, he's borrowed it off somebody else. There's always that visual thing, isn't there, of the person describing their migraine. If they're using one hand to describe it, then usually they've got focal migraine. So for focal migraine, the aura precedes the headache. So we're not talking about someone who has a headache and gets blurred vision with it or flashing lights. You're talking about something, it's ischemia, transient ischemia, that precedes the headache. It's one-sided. And usually it starts off with what we call fortification spectra, which is like a little star-shaped thing in the middle with little lights around it. And it's right in the middle. And then you get like a brighter light that works its way over your visual field So it's right at the end, just there. And it's often about 20 minutes before the headache. Headache is often on the other side.
Somebody who has aura without the headache, I presume that's you wouldn't put them on with them either.
That's non-focal.
But some people get aura, don't they? But they don't actually get the migraine.
That's the same, isn't it?
Yeah,
If you can say, yeah. Or they get aura and vomiting.
Yeah. So,
If it's been diagnosed as migraine, then it would count. A lot of people get, when they're younger, they get the aura and the headache, and as time goes by, they lose the headache. But it's still called migraine because they know that the aura is identical to what they were getting previously.
I've had quite a lot of people describe it as like jagged lines going down the side of the eye.
Zigzags, yeah.
So that's the same as it.
Yeah. But unilateral preceding the headache.
So if the visual disturbance comes after the headache,
It's not an aura.
there is no aura.
No.
That's interesting.
Yeah. There's a good document, it's a few years old now, I think it's the British Headache Society, where it goes at length into discussing how you can diagnose a migraine and what constitutes it and what doesn't. Right, blood pressure. 140 is your cut-off for your systolic, 90 for your diastolic, and whatever with a combined pill, that's your cut-off. So even if it's now adequately controlled by treatment, doesn't matter. The other thing is your vascular disease includes Depo as well, your vascular disease with hypertension. But all your other progesterone-only methods are okay.
So this, sorry, I missed that bit about the adequate control.
You often get people who have a past history of hypertension, and it's been 140/90, but then they're put on medication and it comes down. So you say it's adequately controlled, but it's still a contraindication. Sorry, that's another way of putting it. Is that better? Yeah. Gallbladder disease. And this is a common sense one if you think about it. So, 3 categories. I'll give you the categories. Current, surgically treated, gallbladder out, medically treated. Okay. So where does that sit in your PGD?
Well, it's active liver disease if they haven't had the gallbladder removed. If it's current.
So current
Or
would be
medically.
what? So what's current contraindication to?
It's COC.
Okay. Surgically removed.
Well, it's gone, so it's no longer a problem.
Medically removed.
Well, it's not medically removed, it's just treated.
So you exacerbate it possibly.
Okay. Cholestasis in pregnancy.
So it can't have the COC.
Right, okay. I'm going to come back to cholestasis in pregnancy. Cholestasis previously with the COC. That's a contraindication. Yeah, that's UK MEC3. Actually, they've made cholestasis in pregnancy UK MEC2. So it's not a 1, you can give it, but obviously you just give it with some caution and just make sure that everything is okay.
So is it not likely to bring the symptoms back on?
Well, they found that not. And that's why it was altered with the 2009.
So would you have to counsel them that there is a possibility?
Well, it's UKMEC2, but the advantages outweigh the risks. It's not a nil. It's not no problem whatsoever. Yeah.
Would the cholestasis go along with raised liver function and prevent?
Yeah, it's your obstructive pattern of enzymes, isn't it?
You would have
Cholestasis.
to make sure that that's all back to normal, wouldn't you?
Oh yeah. Absolutely, Hazel. Yes.
So in actual fact, in our clinic, we may not actually be able to ascertain that.
Yes, but it might be 5 years ago.
All right, so that,
Yeah.
okay.
Okay.
Sorry, Anne, could I just
Yes.
what about we get more concerned about fatty liver disease?
I've had one, you know, they've been to CBD and they've been told, oh, you've got fatty liver, but we're not to worry about
It's
that.
liver function tests,
Yeah.
isn't it?
Unless they're done and they're high, we're
Yeah,
not worried
yeah.
about it.
If there's abnormal liver function tests, on the whole, you're better avoiding estrogen until it settles. Yeah. And we've got lots of alternatives these days, haven't we? Breast disease. So, current and past history of breast cancer is a no-no for hormonal methods. Family history of breast cancer without a positive gene is okay, even for the combined pill. Because I know that does come up. And I get that asked that a fair bit. Okay, so you've got to have the gene.
A lot of people don't know.
No, a lot of people don't know. That's right. But then they're in that category until they do know, until they've been tested. That's the query, isn't it? Because they say, "Oh, I'm not being tested until I'm, 25 or whatever." Yeah, yeah. But there again, the risk is probably later in life anyway, and they'll probably come off the pill then by the time it's out of their system. Yeah, yeah.
So sorry, Anne, which category will they be in if they've not been tested and they don't know? This will stay.
Yeah. They're only in a 3.
It would definitely have a...
Yeah, yeah.
What percentage of people put in?
Harriet, Janine will tell you.
I don't know the percentage.
All right.
But yeah, I know it affects both.
So what if we know their mother has the BRCA1?
But we don't know they've got it.
No.
Again,
So surely their risk is higher, and because there are so many options, you would
It's
try and
50-50.
avoid it.
well, you would, but nothing is black and white, is it?
And it's 50-50 whether it gets passed on to the offspring. Anyway, I would be very cautious then.
Yeah.
We had no progesterone.
Yeah.
So we have the alternatives, don't we?
You have to educate
That we
them,
didn't
don't you?
used to have. Yeah, yeah. Just treating everyone as you would treat your daughter or your sister,
Yes,
isn't it?
that's it, yeah.
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 So the question that's on the thing about breast cancer under the age of 45, that could be changed?
Yeah. Yeah. Well, actually, should it be changed? Because again, we come back to the conversation we're having up here. If they said, yes, my mum did, then perhaps there's a little bit of dialogue that should follow that.
Is it breast cancer of any age? Sorry, Rosie.
Sorry, who goes first?
Just, is it breast cancer like family history of any age, or is it under 45?
Well, it's under 45 that's important, because if someone gets breast cancer in their 70s, it's not unusual, is it?
We have a lot of ladies.
Yeah, but it's more unusual and more likely to be a gene carrier if they get it at a younger age.
Right.
Rosie?
I was just saying it's asking that question, and then it's about educating them. So even though, they can be a 1, it's informing them, isn't it, of the studies and the research, so they can also make that educated decision, really, because a lot of women do make that choice, even if they don't know whether it's they've got the gene, to actually think, no, I'm going to avoid it until I do know.
Yeah. I don't know whether any of you read the faculty statements.
You do.
Yeah.
Unless you send them to us.
Yeah. Okay. there was one a month or so ago, actually it was referring to a recent paper on breast cancer and the combined pill. Right, so do bear in mind, it's one paper, and it doesn't mean change in practice, but it was a very good research study. And what they found is that the breast cancer risk varied with the progesterone in the combined pill. There didn't appear in that particular study to be increased risk with levonorgestrel or norgestimate. So that's your pills you commonly use, your norgestimate being your Celeste, and your levonorgestrel being your Macrogan or your Ovrinet, your whatever. And also, they found there was no increased risk if your estrogen was 20, whatever the progesterone.
It's like DVT risk, really, then, isn't it?
Yeah, yeah.
Progesterone.
So, yeah, it is, yeah. So that's one study that the faculty have commented on.
And often you'll find the girls say their mothers don't want them to be on
Yeah.
because of breast cancer. Something that thing comes from them before it even comes from
Yeah.
us.
Yeah. And if they're willing, we know that Cerazette or desogestrel POP is, almost as effective. And if they're happy not to have the regular clockwork cycle, it's a good option, isn't it? Yeah. Diabetes. Two methods with diabetes that you might be concerned about if she's got an opathy, like a retinopathy or some sort of vascular. COC is definite, and the other is Depo. Grand. Okay. Last one. I think I'll just put this one up. Drug interactions. The enzyme inducers. The only two methods that you're okay with are Depo and the IUS. All other methods are affected or probably affected.
Did you say IUS or AD?
On hormonal, yeah.
IUD.
I'm talking about, no, IUS.
Oh, right.
I'm talking on hormonal methods.
Oh, right.
Yeah,
Sorry.
IUD isn't affected obviously
Yeah,
because it's
no.
got no, but the IUS isn't affected either
Right.
because of its local action.
Right, okay.
And Depo because the level in the blood isn't actually reduced by the enzyme inducer. There's no evidence for the implant, but there have been, because no studies done, but there have been some reported failures. And again, it's in your PGD. Just be aware that if someone's been on an enzyme inducer in the past 28 days, the effect is still there, and you treat them as such.
Just important with Pepsi, isn't it?
Yeah. Everyone hear that from Caroline. Pepsi, post-exposure prophylaxis for HIV, which we give for 28 days after a significant risk for HIV acquisition. But it's only 28 days again after they finish that any of these hormonal methods would be effective again.
It might change because they've changed what's in the Pepsi pack.
They have. Have you got the new one yet?
We haven't actually got one.
Oh.
We've asked for one.
Yeah. Yeah.
But Integrity has fewer
Yeah.
interactions.
Yeah.
I'm not sure.
Can I just ask you what you're using instead of your domperidone? Right, okay. Okay. Lamotrigine. Lamotrigine affects combined hormonal methods. Possibly progesterone, but it's not significant. So for the minute, we don't really have to be concerned about that. And the issue with combined methods is that monotherapy with lamotrigine, the level of lamotrigine is reduced when she's actually taking the pill. So she's more at risk of seizures. In her week off, the level will go up and she's more at risk of side effects of the lamotrigine. And I think it was Angie that pointed out that it wasn't very clear in the PGD that this only referred to lamotrigine monotherapy. Is that right, Angie? Yeah. Because if you have it, let's say along with sodium valproate, that effect doesn't seem to be there. So it's lamotrigine monotherapy we're referring to. And we'll make that clearer in the next PGD. Right, okay, so I'm now just going to go through combined hormonal contraception with just a little bit more on VTE. Right, so it works by preventing ovulation, makes cervical mucus thick, and has an effect on the endometrium that makes implantation difficult. We started off with a huge amount of estrogen, 150 in 1960. In the following 3 years, the incidence of VTE was so marked that it was then reduced. And it was found that the effect on the luteinizing hormone, FSH, was equally good with much, much lower levels. Also, we start off with progesterone, which is metabolized to ethinyl estradiol anyway, and then we started using the ethinyl estradiol. So we went down to 50, then 35, 30, and then you got your 20 microgram preparations coming in as well. Every now and again we get a scare. The most recent one was in January of this year, following the French scare about drugs containing cyproterone acetate and VTE. Every time they get bad press, people stop them. Sometimes people don't come and see us for other methods, but the pill is actually a really well-researched method, and it is very, very safe. And when you're actually on it, your risk of dying is 12% less than if you weren't on it. So, I think breast cancer, we've probably already discussed, so I'll just leave that there. This figure here, I think, is just being, it says 24% above the background risk. I think, again, more recent studies would say that's probably lower than that. Cervical cancer, the concern there is if you're on the combined pill for a long time, HPV, human papillomavirus, seems to persist longer than it would if you weren't on combined hormonal methods. And that is thought to be the vehicle for increased risk of developing CA in situ or invasive
So
CA
that's with the
receptors.
estrogen.
Yeah, combined methods
So,
only.
in somebody who presents with high-risk HPV following their cervical smear, but they don't have any abnormal cells, is there a case to say change to a POP?
No. We're talking about persistence. So if someone has it, it's only HPV virus, high risk, is only important if your immune system doesn't clear it. A lot of women have HPV and
yeah, but if you take them off that pill and change them to another one, and that helps them clear it quicker, is that not better?
There's no evidence.
Right.
The only evidence is if you're on it for more than 5 to 8 years,
Right.
which is quite a long time, that you might be
Most
less likely
people
to
will clear
clear
it
it.
within that time anyway.
Yeah, that feels a little bit like a knee-jerk reaction, what you're saying, and I think a lot of people might come off a pill that they're happy with, and then be unhappy with what was offered.
Yeah.
So I would say that would be very overcautious and not evidence-based.
It disappears within 10 years of stopping. That seems really
So which one? This one?
Yeah.
Yeah. But again, it's very difficult because they often say that for, they say it for both of them, don't they? But now, if you notice in the recent faculty documentation for breast cancer, they've taken the 10 out and they've put no figure, and then within several years of stopping. And reduced risk ovarian, endometrial, and colorectal cancer. Right, different types of COC. So the ones we use more and more these days are your monophasics, with your ethinyl estradiol, 20 to 35, different progestogens, and as you go along, the progestogens that are newer tend to be more specific. Has everyone got one of these? If not, I've got spare copies there if you've lost them or whatever. And that's very useful just to refer to what's the same. Drospiridone and your newer pills also have anti-androgenic properties as well, which again are very good for your androgen-induced side effects like hirsutism and acne. So this is basically referring to what's on that sheet there. Norethisterone, first generation. Some people, particularly like your expert groups chaired by Diana Mansour, say we should no longer be using these. They say there's probably a higher incidence of breakthrough bleeding and possibly a reduced efficacy. And I don't think we Have we got any low estrogen in our clinics against
So I
it?
think
Yeah.
I to get
Yeah.
rid.
So we don't use that group anyway. This is the group we use mainly, the levonorgestrel. Is everyone okay? Yeah. And then you've got your so they're progesterone dominant. Then you've got your more estrogen dominant ones, which we do use, and so we'll just talk a little bit more about that later on. We tend to use these more as second line, don't we? And none of these are in our clinics, and they're not included in your PGD. So these are your newer ones. That's your drospiridone, which is derived from a diuretic. The progesterone is from a diuretic, spironolactone. And you've got these two here that have a natural estrogen in, rather than a synthetic. So the idea is that you might be less at risk of things like VTE, and other harmful metabolic effects. But again, that hasn't been evidence-based yet, but it is likely. And then you've got this group here, which contain your cyproterone acetate, and that is mainly used for medical reasons over and above contraception, and primarily for acne. With cyproterone acetate, because there is an increased risk of VTE, you tend to use it just for the time they've got the condition. It improves 3 months more, see how they go. But you can always restart it if you need to. Right, now just looking a little bit at VTE, because that's your main issue. When you've got a young, healthy woman in your clinic wanting combined hormonal contraception, that's what's uppermost in your mind, isn't it? Her risk of VTE. So, in January, this went out to all GPs. So, although the link to blood clots isn't new, it confirms that some types of pill are more dangerous than others. And contrary to what you might expect, when it comes to blood clots, it's the older, cheaper versions that come out best. Now, I think, again, that was in all the newspapers. I think for us, it probably had little impact, because we've been there before, haven't we? Probably 2 or 3 times we've been there before. And I think the faculty, actually, their response was very much, what, this again? So, what their statement was, the risk of thrombosis associated with combined hormonal contraception is well established. Evidence that some products are associated with a relatively high risk is not new. Absolute risk of VTE with all combined methods is small. And when prescribed appropriately, the benefits outweigh the risk. So we could probably have written that, couldn't we? Okay. To put it into context, a woman not taking any combined hormonal contraception, risk is 2 to 10,000. You put her on one of our first line methods, 3 times the risk. If you go to one of the other methods, again, like your Marvelon, Femidine, Gederol, it's 2 to 3 times higher than that. Sorry, from 6. That was up to 12, so it'd be twice that. Twice the risk of an older generation pill. Just while we're on this, it's probably worth saying a couple of things. One is, while she's pregnant, that figure goes up to 29 per 10,000. Postnatally, it's more than 300 per 10,000. And another couple of things is that when you, in the first 3 months of her starting a combined pill, the risk is actually 5 times more than the figures there.
I wonder with these girls that often start and stop.
That was just about to come out of my mouth. Yeah. No, that's so right, Angie. Yeah. Because if you have a break of more than 4 weeks, like people who stop and start, break more than 4 weeks, when you go back on it again, you have that high risk again for the first 3 months. So it's not a good idea to do your stopping and starting for that reason. Right, okay, so you tell me, I know you know the answer to this, what's your first line?
Definitely on a gesturing.
Anybody disagree?
30 micrograms.
Yes.
So obviously the 20 micrograms more increased risk of unscheduled bleeding.
Yeah.
So 30 microgram levonorgestrel, you're over 90 microgram on your liver, you're going on.
Perfect answer. Everyone hear it? Yeah.
So I got the wise.
Okay, so we choose that. That's just like Janine just said. If you do decide for whatever reason, after discussion with your patient and her choice coming into it, that you use one of the neuroprogestogens, then you just need to inform her. And now we've got it on our templates, haven't we? So we won't get caught out. And this is quite important. And again, you know, the faculty keeps stressing this. If she comes in and says, I want Marvelon because my friend's on it and she's happy on it and that's the one I want, we want to give her a pill that she's going to take. And it's okay to do that. And just document, you know, why you're doing it. Right, so just looking at your PGD now specifically, these are your indications. So it's a woman wanting ongoing contraception, a woman with bleeding problems on your 3 methods, your implant, injection or the IUS, and women who are going for a termination of pregnancy. So you can give them their supply of pill rather than asking them to come back to you after they've had the termination. You can also do a quick start after you've given emergency contraception, but if there's existing risk of pregnancy and you start it, that's outside your PGD, okay, unless you've just given emergency contraception and any unprotected episodes are covered by the emergency contraception. If it's for cycle control, obviously you can start any time that you want.
Can I ask a question?
You may.
Thank you. If they are coming to you and have a really irregular cycle and they say they've always used the condom, is that acceptable to start them on a hormonal method if you're happy that they are good condom users?
I would feel that was okay because you're not doing any harm.
No.
And that's why even if they're not using a condom, I invariably will say to you, if they're at risk, start it and do a pregnancy test in 3 weeks and just tell them that it's not going to harm the pregnancy.
Yeah, but that's outside our PGD.
That's outside
PGD. You
PGD.
accept that condom use,
If it's
so you're
yeah,
excluding pregnancy as much as you can,
yeah,
is acceptable within our PGD.
yeah. In your PGD, it says using a method of contraception, doesn't it? And if it's unreliable use, then obviously not. But if they say I've used it consistently, I've been using it for years, I haven't got caught out, I think that would be perfectly okay. Thanks. Right, so standard and tailored regimes of taking. Right, the traditional one, 21/7, you have a 7-day break. Try cycling. Joy's nodding. 3 cycles back to back with 7-day break. Extended use. Take it continuously until you start to bleed. And when you bleed for 3 or 4 days, you have a break of 4 to 7 days. I thought this would actually be quite useful. Just want to have a little look at this.
Why when you try cycling, why do you have to go to that 7 days when you don't on the kind of continuous use?
Just here, I've put in continuous use a 4-day and a 7-day.
Yeah.
Right. The answer is a lot of women get used to starting a pill packet on a set day of the week, like a Sunday. So it'd be fine to say have a 4-day break, but there's probably more room for error if they're starting on a Thursday rather than a Sunday. That's probably the only good reason, Joy. And again, the same said for this. You know, for your continuous in the guidance on it, it says 4 to 7 days, but a lot of people would go for the 7 purely because you're starting on the same day of the week. But, you know, if then she forgets to start it, she's more at risk than she would have been had she had only a 4-day break. So moving on from that, the benefit of having the longer times of taking the pill is that you're not having, let's say if you have headaches or mood changes in your pill-free week, you're going to have them less often, aren't you? Because you're reducing the number of times that you have periods. If someone's anemic, it's going to be better if they're on one of the extended methods of taking it.
So in theory, someone with continuous use may not have any bleeding and could be on it for full 12 months and not have any breaks.
Well, I think we've created a problem by calling them periods.
Well, yes, because they're not popular.
Yeah, they're not periods, are they? Withdrawal bleeds. Yeah. Okay. So, that's generally your assessment. And I think probably everyone would agree that we cover that, don't we? Follow-up generally is usually about 3 months later, because we give 3 months supply on that first occasion, although we might reduce that if we had other concerns, particularly in young patients. If the side effects after 3 months, we generally would give only another 3 months supply of a different type, and then reassess. And after that, say 6 to 12 monthly. This is something we drew up a few years ago. In fact, it was mainly Sue that put her mind towards this, for when we might consider giving 12 months supply. Now, it's very cautious and probably could be a little less cautious, but it's a good guidance as to when you want to give 12, particularly if people have been on it for a long time. And maybe we should do a bit more of that.
So this is obviously after your 3 and your 6 months.
No, after your 3.
Right.
Could do it after your 3. Maybe be even more likely to do it after your 6.
I've done it a little bit more since we've got both better stock of pills in the cupboard.
Yeah, yeah. Actually, that makes a difference as well, Jackie, doesn't it?
Because
Yeah.
there wasn't the stock in the cupboard to do it.
That's why it's how you prescribe it. You can prescribe it. with
Yeah.
stock.
Okay, so also combined hormonal contraception might be associated with mood changes, but there's no evidence, and there's no restriction on prescribing it in depression. No evidence it causes weight gain. All hormonal methods can alter appetite. Flights more than 3 hours. Again, you think about VTE, tell her to get up and walk around and whatever, wear her socks. Trekking. Again, you probably won't remember that figure of 4,500 metres, but just have it in your head, you can always look it up.
Is that Everest or
It's
not
Machu
Mount
Picchu.
Who knows the heights of
You know
mountains?
Machu Picchu,
It's like
anywhere where you get altitude sickness, definitely. Yeah.
Okay, right, so now I'm just briefly handing over to you again. So just have a quick look at these. I'm going to just flag back to it in a minute. And here we have 40-year-old Vicky, right, who's a non-smoker, normal BMI. She's fit and healthy, on no medication. She saw you 3 months ago and wanted a method that gave her a regular bleed. So you gave her your first-line pill, but now she's got some problems. So we've got 8. So if I just 1, you're dealing with acne. 2, breast tenderness. Nausea.
Are we allowed
you've
to
got
use materials?
Lots of libido. Weight gain. Irregular bleeding. Yeah. And U3, headaches.
We're allowed to use one algorithm. Oh, you came back algorithm.
Right, 5 minutes. No, 4 minutes. Okay, group 1, acne. In loud voices, please.
Marble on Celeste.
Do you want to say a bit more than that? No. Right, the answer from group 1 is Marvelon Celeste.
So we could go for a more estrogenic pill.
Thank you. Okay,
And
so...
a different progesterone.
Yeah, is that okay? That's fine. Right, so combined hormonal contraception, all types can improve. And there isn't a huge amount of evidence to say what's good and what's bad. However, the suggestion from this group is a good one. And yes, we would probably, if they were on a progesterogenic type pill, move to a more estrogenic one, such as desogestrel or gestodine. And also, if that didn't help, you could then, in our case, refer back to GPs for other methods, particularly anti-androgenic methods. Okay, thank you. 1. Right, 2. Breast problems.
Well, we thought it was implants were probably possible. Yes. Yeah. But having said that,
Did you say that to her?
we'd lower the estrogen, so we
Yes.
take it down to a 20 microgram pill.
Yeah.
And we put her on Femidet or Mercilon.
Okay.
And also probably quite good cycle control with both of those as well, given they're only 20.
Yeah, and if they weren't helpful, what might you do?
Put her on something like Cerazette.
Right, okay, thank you, group 2. I think you've probably got everything. So, yeah, lower your estrogen, changing to a different type, alternatively Cerazette, and then just your other methods that sometimes you suggest, your evening primrose. Okay?
To win on the acne.
Right. Now then, nausea, group 3.
She's not present.
Check that pregnant, thank you, yeah.
Discuss with her when she's actually taking it.
Yeah.
So maybe suggest taking it at night instead, or
Yeah,
she's taking
good
it
Debbie,
food.
yeah.
And tell her to just try those things if she hasn't already.
Yeah,
And if it's still persistent after another, say, 3 months, then drop her estrogen to a 20.
yeah. And if it still persists? Okay, lovely, very good. Right, mood swings.
We weren't lost of libido, but we don't mind being mood swings as well.
Okay, maybe did I miss out? Or maybe I missed out mood swings. Did I? Did I give mood swings to anyone? No. Okay, so mood swings. There's no. We've sort of said it before. There's no real evidence, but a lot of women have mood swings for other reasons. But it's so much easier to blame your pill. So usual advice is like your lifestyle things, but sometimes it is helpful to change. We don't know whether we're doing it for us, for them, and sometimes it does appear to have beneficial effect, but again, no evidence.
So you wouldn't particularly recommend a particular pill then?
You'd do a change to a different progesterone
So
if you're doing it. Yeah, but you would, if you got on a progesterogenic pill, there's no point putting on another one. You'd probably go for estrogenic, which is on estrogenic, you'd probably go the other way, wouldn't you?
Right. Yeah, but if we start everybody off on the best generally, which would you tend to go for then?
I'd go to gestodine or desogestrel. Okay. Loss of libido. Back group. Yes, that's what I always say as well.
What was that? You check for other issues first of all.
Yeah.
Relationship issues, etc.
Yes.
See if that had any contributing factors. And then we've changed our mind about 3 times, and we would like to refer to our decision tree that we have in clinic. However, we haven't got it.
Yeah.
We're thinking about change in our estrogen.
Her estrogen.
Progesterone.
Yeah.
But we haven't decided what we're going to change it to, did we?
Well, if let's say part of her loss of libido was associated with vaginal dryness, would that maybe give you a direction to go in?
Or estrogen.
Yeah, that's what I was saying.
Higher estrogen, didn't you?
Yeah, change in estrogen.
Yeah. So if you like your pills, like your progesterogenic pills, like your levonorgestrel, one of the side effects of them is actually vaginal dryness, and often loss of libido, you get dryness anyway. So changing to more estrogenic. Yeah.
Yeah.
Is that what you're saying?
Yeah.
Yeah.
Can you say the pills that you
That's
want to change
what
to?
Yes. Yes. You will change to a pill lower down here,
Yeah.
like your desogestrel or gestodine. They're your estrogen. It's just Femidine Marvelon. Yeah. Is it easier if I say them?
Yes.
Actually say them?
Yes.
Okay.
Yeah, but we're going to change to branded, so you should know that these are just.
Well, Joy can work on that later, can't you? We'll stick with
I work
you.
on the flow chart, but
Yeah.
I've had to write them off.
Yeah, that's fine. Absolutely fine. Okay, so loss of libido then, often nothing to do with it, is it? See if it happened shortly after she went on the method that you've given her. In which case, you might want to think, is it other things like vaginal dryness? Often it's just due to relationship and just simple advice. And it's a bit like the mood changes, you think it's probably something else. But she's come to you for wanting you to do something.
Just changing their pills makes them think.
Yeah.
It's like the placebo.
Yeah.
That actually, if they convince themselves it's their pill, you need to change it simply.
And
to
if nothing changes, maybe then they'll look at other things, but not until you've done that. Yeah. Okay. And then moving to your Femidine Marvelon type pills. Okay. Weight gain.
If it was Victoria Beckham, we were saying that.
Okay. But seeing as she's become a little distorted, what we now about is only 3 months, right? So what we're going to tell us.
Lifestyle to begin with, exercise, what she's eating, what she's snacking on. There's no evidence that the pill makes you gain weight. Well, that's what we said. A lifestyle, exercise, what she's doing. It's very easy to put it down to the pill that she's put the weight on. But is it other factors? And we will go into all that with them. Was there anything else? We were just saying that sometimes when you leave school in the 6th form, for instance, and you start a job, you do notice a big weight gain because they're not doing PE anymore, they're not doing any exercise. And if they're sat in an office job, they're suddenly putting weight on, and sometimes they don't think about it, that they're using the lift, they're not even walking the stairs, and they're not...
Yeah, it's a lifestyle.
So there's other issues as well.
Yeah. It's often in those first 3 months though as well, because you've got that hormonal surge, haven't you? And actually, if it's going to stimulate your appetite, that's often worse in those first few months, and it's how you react to that. So it's sort of educating them about, and often weighing them, because they feel they put weight on, and sometimes when you weigh them, they haven't actually put much on at all.
And some women, that's the bloating. Some women react to the digestion, don't they? Just by sort of that bloating feeling.
So if they were adamant that they wanted it changing, you would change it to a different progesterone.
Yeah.
But you've also got to consider if their weight gain takes their BMI above a certain level, you might have to take them off the COC anyway.
I mean, it is watching it, because some women do put it on, but it's whether they feel it is definitely that, isn't it?
Yeah. Rather than the feeling of the bloating.
Yeah. I think with young people, alcohol is the big issue, because they don't realise how many calories are in alcohol.
Yeah. Okay, so the only method that actually puts weight on you is Depo-Provera, isn't it? Is the injection. And that puts on 2 to 3 kilograms in the first year. But otherwise, there's no causal relationship. And then I think, Phil, you've covered it really. And change of method, but no good evidence. Okay? Everyone all right with that? Unscheduled bleeding. Okay?
Compliance.
Compliance, yes.
Has she missed any pills?
Yeah.
So yes, and then screening. What we're looking at? Yeah, screening and up-to-date smears.
Yeah.
Yeah. Then we're looking at changing it for
Tefemidine for better cycle
better
control.
cycle control. That's brilliant. One more thing, if that bleeding continues when you put her on the Femidine that you've changed it to, there's one other thing that you need to do.
Yeah,
you have to have a look. Yeah, you have to have a look at the cervix, don't you? Yeah. Thank you. Okay, so I think you've covered all this. Exclude other causes, check your compliance, screen, cervical examination, change. Oh, you got everything right. Change into gestadine. Okay, right. Headaches.
So first we talk about lifestyle, so your diet, fluids, sleep, etc.
Yeah.
Talk about maybe getting their eyes tested. And then we get them, when is she getting the headaches? If she's on COC, is it during, when she's taking a pill, or is it in a pill-free week?
Good.
If it was in a pill-free week and they weren't migraine or non-focal migraine that developed while she'd been on COC, then we suggest tricycline or continuous use. And then we'd also talk about what triggers it and what gets rid of them. And then if they were all still continue, we'd change to a progesterone-only method.
Perfect answer. Okay. Don't know, I've got anything to add. Right, so careful history, look at other reasons, stop it if it's migraine with aura. Pill-free week, you want less pill-free weeks. If it happens on your active days, probably switching to Cerazette will be a good idea. Right.
What about those people who say they want the regular cycle, but they get the headaches in the sort of first few days after starting it each month? You don't have to start.
Well, then the less periods, the better.
But they still want the regular bleeds. Would you reduce the estrogen then? Would that have any effect?
It may well do. It's worth trying, or changing the progesterone again, isn't it? Yeah. Okay, Evra? So, Evra in your PGD is where there's compliance issues. There's the same contraindications as we've been talking about already, so everything applies. And as you know, it's one patch 3 weeks and a patch free week. Looks to be maybe a slightly higher risk of VTE. And outside of licence, under the age of 18, should let her know. And it is expensive. We don't include it in the 12-month supply.
Why is it outside licence for under 18?
It's just the manufacturers, the SPC. So it's the implant.
It costs
Think
a lot of money.
think how many implants we put in under 18-year-olds outside of licence. Right, and then POP. We very rarely use these, certainly in our area. I don't know about you. Right, okay. We tend to use desogestrel. Taking it every day. This I find quite useful to look at. Look how effective this is in your older women, but in your 25 to 29-year-olds, not quite as effective at all. So just to bear that in mind.
So what about in your younger ones, even younger than that, your 18 to 24?
Well, they're similar fertility, aren't they? It starts to fall off in your 30s, doesn't it? Yeah. Fertility. Right, makes the mucus thick so sperm can't get through, affects the endometrium as well, and inhibits ovulation in some cycles, but for Cerazette it's 97% of cycles. Reasons you might want to choose it: lactation, side effects to estrogen that we've already discussed and you've already sort of said when you would switch to it, and contraindications in your PGD. Again, we've gone through them all already with the UK MEC section, but your POP, the progesterone-only methods would all be okay. Now, the PGD doesn't include using this for unscheduled bleeding with other methods, but it does appear to help some methods. I'm going to just talk a little bit about that. I'm going to offer you a little paper you might want to read, but we'll do that in the implants section in a second. Right, side effects. The main side effect is it doesn't give you the nice regular cycle that you get with your combined methods. 1 in 5 amenorrhea. Most people really like that. Some obviously don't because they feel they need to have a regular bleed. So 40% will bleed, continue to bleed regularly, and 40% will have erratic bleeding. No evidence of weight change, doesn't cause depression, no significant effect on thrombosis, stroke, or ischemic heart disease, and no significant effect on breast cancer. So the desogestrel one inhibits ovulation in 97% of cycles. You've got that 12-hour window period. Because it suppresses ovulation, you've got fewer cysts, less pain with periods, less ectopics. You're more likely with desogestrel, Cerazette, to end up at a year with little or no bleeding than you are with the traditional ones. So, when you would consider to using it is when you're going to go for a progesterone-only oral method and you know that 3 hours isn't going to work. Young, highly fertile, failure rate is higher with the traditional ones. Weight. Those of you who've been working in contraception for quite a while, you'll know we used to give 2. Yeah, if they're over 70. We don't do that anymore. And there's no evidence that you should give 2 of the desogestrel ones, the Cerazette ones, if the weight is above 70. History of ovarian cysts, you want to do things to suppress the activity of the ovaries. Again, for ovulation, you want to ectopic pregnancies. Ectopic pregnancy requires ovulation, so a method that suppresses ovulation in 97% of cycles, like your Cerazette is going to be better for her. And also, there is the new guidance on hormonal contraception and women with cardiac disease, and I think you're all aware that in there it actually said, well, you're getting the information that you need to decide what is appropriate hormonal contraception for a woman, just put her on Cerazette. You're not going to do any harm. Okay, we come back to this again, January papers. So saying that these methods that require the woman to take a pill every day, they aren't as good. And we know that perfect use, it looks wonderful, doesn't it? But when you come on to actual use in any method that requires the woman to remember, then the efficacy isn't great. So if you look at the bottom 3, typical use, it's exactly the same as perfect use. So there's a real push, isn't there, that LARC methods are preferable for efficacy and cost. So the cost at 1 year outweighs the cost of the methods like the pill. Right, so the safe, effective, more cost effective, recent NICE guidance once again supports their use, still underutilised, and particularly with intrauterine contraception tends to be used more in older women. So if you look at this graph here, let's find my laser. So you've got 64% of IUS is in women over the age of 36. And this is only 2011. It's not that long ago. The implant primarily in your under 29-year-olds, 67% is in your under 29-year-olds. In the depot, it's probably slightly more evenly spread, as it is with the copper coil. This might be skewed slightly because it does, in this particular study, include women who wanted the IUS for bleeding problems as well. If you look here, these are your LARC methods. and I think it tops up to 13, so 13% using LARC methods, and more than twice that using no method. Right, so the implant. Small, flexible subdermal rod, etonogestrel, 3 years. The release rate decreases over the years. Very effective. When you've removed it 4 to 7 days after the hormones have been excreted from the body. Bleeding problems, as we know, are the biggest issue. No weight restriction, no upper age limit, no effect on bone density, is affected by liver enzyme inducers. These are your continuation rates. As with the progesterone-only pill, you've got 1 in 5, 20% having amenorrhea, but you've got 25% frequent or prolonged bleeding. And the issue with the implant is if they have got it, it's probably not going to settle. At this point, I think, I'll just point out this paper here, which you may have a copy. And the key things in the paper are that when people come to us, maybe quite early on, we've fitted the implant in, and they might come back to us, let's say 3-4 weeks later, rather than the usual 3 months. We haven't given them a follow-up because we don't with the implant. We've said come back to us if there's issues. If they've come back to us with an issue, even though a few weeks later, it probably is an issue for them. And I would say we don't actually have to wait. We don't have to sort of say, well, you haven't given it very long, you know, why don't you give it until it's been in for 3 months, and then we'll see how it's doing. But there's a good reason, I think, for even at that stage to think, can we make this more acceptable for this woman? And think about giving her the combined pill to regulate it at that point. Would everyone be agreeable with that? Because sometimes they become so disillusioned and they've had a negative experience, you sent them away. The next time they come back, they're saying, I want it out. And maybe we could preempt that. Yes, Joy?
So that's great, but the reason why we put the implant in some is because they can't take the COC. Yeah. What do we do when they come back and they're bleeding?
Right. The only effective thing that the faculty will support is the combined pill, and the recommendation is the levonorgestrel combined pills like your microgynon and your Ovinet. However, the bleeding, I'm glad you asked that question. The bleeding with the implant is supposed to have a different mechanism at different times after the implant has been put in. In the first few months after it's been put in, the effect of the low dose progesterone on the endometrium is to make it unstable. And that instability is mediated by prostaglandins. So probably your most effective method, if you can't use the combined pill at that point, is a non-steroidal anti-inflammatory. Okay? Yeah. If you were to give Cerazette at that point in time, early on, you're probably just adding to the low dose progesterone because you're not increasing the level that much. So you're probably not going to have a huge amount of effect. However, on the other hand, preliminary studies have shown that if you've had a woman who's had quite a good bleeding pattern on the implant, she's had either a regular cycle or she's had amenorrhea, and then it starts to become irregular, the level of progesterone that she's been getting has been reducing since she had it put in. And if at that point you put her on Cerazette, it may well be really quite effective in sorting out her bleeding.
Cerazette's not in our PGD, is it?
No, not in PGD. No.
So for your younger clients who do not tolerate bleeding and they will return very, very quickly, what you're saying is this non-steroidal
Anti-inflammatory.
from GP?
Yeah, from GP usually. It'd be very expensive for them to buy it over the counter on a regular basis. Yeah, GP.
But what happens then if you go to the GP and the GP is not aware of this evidence?
It's on the guidelines. It's on the guidance
Yes.
in the faculty.
Yeah, but if it's not somebody who's particularly...
But we've got that with everything, haven't we? Maybe
Yeah.
you could do a little letter to support your patient.
We still have ladies come in that get repeat prescriptions for the combined pill.
Without seeing a GP.
Like, without seeing anybody.
Yeah.
Yeah, oh yes, absolutely, yes. But we can only regulate what happens in our clinics, and you can inform GPs who have a huge amount of things to think about other than contraception of something that you're an expert on.
So are you saying, can I just clarify, are you saying that really in the first year where the levels are the highest with the implant, if they're having irregular bleeding and have had it from the outset, they should really be going and getting these anti-inflammatories rather than going on the
I don't think anyone said it's the first year.
Well,
I think they've said it is the irregular bleeding that is from the outset, however long it lasts. That you can give your Cerazette, but it's less likely to be effective than a non-steroidal anti-inflammatory.
Do they recommend it?
No.
No.
And do you think there's just thinking to back up what we're doing, if we are going to be sending people to the GP, that we should have a standard letter?
To do that?
Yeah.
So would you give them would you give them Regeneron if they had no other...
Yeah, first choice.
contraindication?
First choice, yeah.
It's only if there's a contraindication
To estrogen, yeah.
that you would give them the non-steroid.
Exactly, yeah. Was everyone clear about that? Because we started off with the combined hormonal contraception, then we moved on to people who have contraindications to estrogen.
Can I ask, I seem to remember a conversation where you were saying if bleeding reoccurs after year 2, would it possibly be worth having a new implant put in sooner rather than later?
Yes, particularly if your Cerazette didn't work and you had no other reason. Again, you do all the investigations for a woman with unscheduled bleeding that could have other causes other than hormonal contraception. But yes, Joy, particularly if it's in the last 6 months, because we know that level is less. Yeah. And again, just following on from that, if you had a woman in maybe the last year of the implant who had irregular bleeding, you give her a Cerazette and it sorts it, but she says, I don't want to be taking a pill every single day. That to me would be a good reason for doing an early change as well.
How long can you give like the COD? Is it just 3 months, or would you just carry on with the implant in situ?
You can give it for much longer than 3 months. A lot of us would give it for 3 months, particularly if it's in the very early stages, and say, well, why don't you then see how you go without? But there will be no reason, provided she's got no contraindications to estrogen, why you couldn't repeat that. And also to use it in any of the ways we said before. It hasn't got to be the regular monthly. It can be extended use as well. Yeah. Okay. I've left this slide in because a few years ago I know that some people used to use, I should probably say desogestrel pill rather than Cerazette, used to use it to see what the bleeding pattern was like on the implant, and it's different for different women. It doesn't give you an indication. So the implant, it can help pain with periods, no increased risk, thrombosis, stroke, well probably not no significant increased risk of VTE, stroke or ischemic heart disease, no significant effect on bone density, no evidence it causes weight, mood or libido changes, and acne can go either way. So time of fitting. What do you tell her? You tell her about the insertion procedure, any problems that might occur, which occur rarely. No routine follow-up, but to come back to us if any problems. No evidence of delay in fertility when it's removed. Some people confuse it with Depo, don't they, thinking it takes a while to get out of the system. And again, I put this in. because of the mucus thickening effect, when you remove it, unlike a copper coil, or like any coil, you don't have to go back 7 days and say, I need to give you emergency contraception for sex that you had 2 or 3 days ago. You assume that she's covered. Weight. There's only one study that has looked at implant and weight, and that demonstrated that even up to 149 kilograms, that there's no increased risk of pregnancy. Maybe more bleeding problems, but no increased risk of pregnancy. However, we do know that measuring the hormone level, it is lower in heavier women, and so we can't definitely say in a black and white fashion that there's no reduction in contraceptive efficacy, but there's no evidence to prove that there is. So, the manufacturer says that an earlier replacement can be considered in heavier women. And as a response to that, the faculty said, well, perhaps we should go for maybe consider if over 70 kilograms. And then once again, well, there's probably 2 things to say here. Weight seems to be more important than BMI with this. And perhaps what is worth saying here is if there's changing bleeding pattern, let's say someone had amenorrhea and she's over 70 kilos, and in the last year she starts to have a regular bleed. You know, that just might make you think, you know, shall I change it? And then just a few other issues. I think we've said it's not licensed under the age of 18, but there's no specific restrictions. Still black triangle status is next one. It's got the barium in, which means you've got to report every side effect, but I don't think we actually do. But certainly any significant side effects should be reported using the yellow card system. We know it's not recommended for women using enzyme-inducing drugs. And just to state, it's not a contraindication, but someone who's diabetic, it can affect peripheral insulin resistance. So just to mention it to them, if, you know, they might want to sort of mention it to their diabetic nurse that they've got the implant put in. Practical issues, for those of you who fit and remove. Usually we put 2 into the same arm. You tend to put it in parallel rather than exactly through the same channel that you remove the previous implant. And we usually switch after 2 implants in one. And that really, in one arm. And the reason for that is based on Norplant evidence, where there was, you had more rods obviously, and there used to be atrophy in some women if you had more than a couple of implants in the same arm. So I must say I haven't seen atrophy as a result of 2 implants, but I don't know whether anybody else has. But it is recommended, you know, I think if a woman says, no, I only want it in that arm, that in my mind is perfectly
what if
okay.
there's been like, they've had 2 in one arm, but there's been a long gap since they've had one in that arm?
Then that will probably be okay.
Okay, and if you get to your 5th implant, you go back to the other arm again?
I would assume so. Yeah. The biggest issue with the implants is you go higher up in the arm.
Yeah.
And to me that limits where you can't go into the axilla, can you? Yeah. Ventral fractured. Now, the advice we've been given has changed a little bit over the years, but I suppose it's with more evidence. So the release rate is only slightly increased, because if you think there's a slight more, when it's broken, there's a slight more surface area, isn't there, for the hormone to be released from. And it doesn't affect contraceptive efficacy. I suppose it would be actually higher rather than lower. And it says the decision whether to replace is really up to the woman, and you need to support her in that decision that she takes. You haven't given her the information that it's not going to affect her contraceptive efficacy. When you take it out, make sure it's all there, and you should report it. Yellow card again.
That's interesting for those girls that try and because they want to get pregnant, isn't it?
Yeah.
Choosing the chance.
Yeah. Yeah, good point. Right, and then just Depo before the break. So aqueous solution, pre-filled syringe, deep IM injection here. Use deltoid in a very, very fat woman where you're worried that you won't get into the muscle. Failure rate very low. Every 12 weeks. Probably in the new guidance from the faculty, they might say every 13 weeks, which will be consistent with cyanopress, because there's very little difference between the intramuscular Depo-Provera and the subcutaneous cyanopress. It's just the license for cyanopress was 13 weeks. And so when they looked at all the cost effectiveness and whatever, cyanopress actually came out quite well. Whereas if the faculty say Depo is also 13 weeks, it puts a slightly different slant on that. But that hasn't been published yet, that is in the pipeline.
But that would still, so then you've still got that 14 weeks.
Set won't change.
So it's a nightmare because if they don't turn up at 13 weeks, so you better to bring them back at 12.
But then you could say the same for cyanopress when we eventually get it on PGD, couldn't you? Because that is licensed for 13 weeks, but you're only allowed up to 14.
Yeah,
yeah.
It just gives you less leeway. It's not good.
Are we going to get them?
Not at the minute.
No.
The benefit of that will be cyanopress is when it gets its license for self-administration. Then that reduces costs quite substantially because there's no clinic attendance, no use of health professional time.
I just wonder how many women will be happy to give themselves an injection.
Yeah, I think in the trials that the company have done, it's been very acceptable. People travelling abroad.
Yeah.
We're in post-natal now.
Yeah, they are. They are.
Saying a lot.
Yeah. Okay. Right. Okay. So inhibits ovulation. It does all the same things that progesterone-only methods do. Thickens cervical mucus. Endometrium becomes unfavourable. Much lower mortality and serious morbidity than the combined methods because no estrogen. Give it the first 5 days of cycle. It works straight away. Any other time, 7 days to work. Following emergency contraception, you can give it, but it's not ideal. You'd be better giving another method, a bridging method first, such as the oral contraceptive, and then exclude pregnancy, and then give your Depo, because once you've given it, you can't take it back, can you? You give it immediately after first or second trimester abortion, and at any time postpartum. Can be used up to 50 years of age. The SPC doesn't say 50, that's faculty. It's okay with raised blood pressure, VTE, high fats in the blood, any sort of migraine, uncomplicated diabetes, but as before, not any of your opathies or vascular disease, gallbladder disease because of no estrogen. It's got health benefits. It's good for menstrual bleeding because a lot of women have no periods whatsoever. By the same reason, improves pain with periods, improves endometriosis, and can give protection against ovarian and endometrial cancers. Main things to discuss are the bleeding problems, but unlike with the implant, if they get bleeding problems initially, it's very likely that they will go away and she'll end up with no periods or very, very light bleeding. Always discuss bone density. Weight gain, 2 to 3 kilos first year, and particularly it tends to be more your overweight women who are going to put on weight rather than your skinny ones. And if you put on weight in the first year, it's actually likely to continue. Okay. Slow return to fertility. Right, I'm going to just say a little bit about it. So each of these things that you're discussing when you first see her, we'll just say a little bit just about each of them. Okay, so you've got almost half of women have no periods at 1 year. And that's a good thing to be able to tell them, isn't it? Less than 10% have prolonged bleeding. And again, as I just said, it does get better with the Depo, with more use, with more duration of use. And we can control the irregular bleeding as with all other progesterone-only methods. And methylmalonic acid is also helpful. Your PGD allows you to give it up to 10 weeks after the previous one. And again, you may want to do that particularly if the bleeding is towards the end of the 12 weeks. Bone mineral density. It's a small loss in bone mineral density, and it usually returns to normal after she finishes. And there may be an association with increased fracture rate, but really the evidence for it is really quite poor. Recommendation is every 2 years you sit down with her and you discuss it, but I think in practice we probably discuss it most times they come to see us and check there's nothing new in the family history. However, if you have someone who has other risk factors for osteopenia, such as anorexic, athlete, amenorrhea, on certain forms of medication even, like carbamazepine, or thyroid problems, you wouldn't consider it a suitable method. And this looks at your different age groups. So your adolescents, under the age of 18 or 19, they might not achieve the peak bone mass. And then older women, perimenopausal, bones might be getting a little bit thinner anyway. Just a bit more discussion required. Okay, no restriction on weight gain, but as we've said, those who put on weight will probably continue to do so. Fertility, you tell her, don't you, a year. It can take up to a year, sometimes it's less, but to allow a year if she wants to conceive.
Does it matter how long we've been using it for?
I think probably if they've been using it for a very short time and it hasn't deposited in the organs in the body, which is what it does, any tissue in the body, then you're going to get a sooner return to fertility. But I suspect if she's been on it for over a year or so, that advice would stand. Very recently, there's been a question over whether Depo-Provera can increase the risk of a woman acquiring or transmitting HIV. I haven't sent the papers round because it is very much a query at the minute. Some studies, there's quite a lot of debate, quite strong debate one way or the other. But for the minute, it's just to have an awareness of it.
What's the relationship? Why
They're not quite sure. It might be the effect on the vaginal mucosa. But there could be other reasons for it as well, Rose. There's quite a lot of literature looking at it. And some people are actually saying you shouldn't be prescribing this in people at high risk of HIV, but others saying, look, the evidence isn't there. This could be all progesterone-only methods, and it's more important that woman has a reliable method of contraception, and particularly in areas where HIV prevalence is high, there's little access to contraception, and Depo is one of the methods that is sort of, quite highly used because it's only every 3 months. Right, and Cianopress, so we awaited the licence for self-administration. Again, more recent evidence that you are getting more reactions to the injection than you are with the IM injection because it's subcutaneous. So perhaps that's something we have to just, again, be aware of. The use so far, other than when it gets its licence for self-administration, will be maybe anticoagulants, because you're going to get less bleeding if you give it subcutaneously in a woman on anticoagulants, and in women where you think that you're not going to get to the muscle because she's got so much adipose tissue. Right, I can have a rest now.